Okay, so part of what my job is to first of all figure out if you have too many particles or you have abnormal cholesterol, maybe you have a low HDL. But once we do that, it's not about just prescribing a med now to fix that problem. Now what we need to do is figure out, okay, why? Is it because of a genetic problem? Is it because you have thyroid disease? Is it because you have metabolic syndrome or insulin resistance, prediabetes? Is it because there's something else going on? Do you have vitamin D deficiency? What's going on? So we don't just look at those, we don't just look at the cholesterol numbers or the lipoproteins, even the NMR. We actually look at all those other things. We rule you out for thyroid disease. We make sure you don't have diabetes or the earliest stages of diabetes before you have an abnormal blood sugar. We make sure your vitamin D level is normal. We're doing all of those things, and that's step one, is to identify the cause of the problem. Because as I've illustrated, there's people who have high cholesterol who really aren't at risk or who don't ultimately go on to develop heart disease. And we don't want to just give them all medication. We want to figure out whether they're at risk or not and whether they truly need it or not. Now, if I identify a patient to have this receptor problem, that patient needs a medication. And I'm actually not going to tell them to just diet and exercise. I'm going to give them medication and diet and exercise at the same time. Other patients will more frequently do a diet, exercise, and maybe some other assessment of things like thyroid and blood sugars and other things, and treat those things first before we think about addressing the cholesterol. Because we have a lot of people whose cholesterol normalizes once we fix these other problems. And that's important. You know, it's not just about being given a medication.
Dr. Dall?
Yes. Yes.
You can test for how many LDL particles are in the blood, but how do you test how large they are, how small they are?
The same technology that basically counts how many LDL particles are present also tells you whether the particles are small or large. And it gives us a lot of additional information that basically gives me, as a lipidologist, a window into the genetics. And not only just into the genetics that put you at risk for heart disease, but also into the genetics that put you at risk for diabetes. And with the type of blood testing that we do, we can really identify diabetes years and years and years before your blood sugar's abnormal. And if we can do that, if we can identify that risk, we can actually hopefully prevent diabetes from ever coming on by putting people on specific types of diets and following them very closely. Sometimes even using very low doses of diabetes medications early on to help prevent that. And that's a lot about what metabolic syndrome is. The one thing I wanted to illustrate about this whole concept of the size of the particles is that you can actually have normal sized particles, the large particles, which are usually more optimal to have, but they might only be half full of cholesterol, so you still have too many of them. So I'm saying, so there's lots of different scenarios that we can come up with here. Okay. Now, one window into this advanced testing that we're talking about, which you may not all have, and you certainly don't have access to as regularly as routine testing. If you have a high triglyceride, or you have a low HDL, you can pretty much assume you have too many particles. Because you can see here what happens. As triglycerides go up, really even over 100, you start to create a surplus of LDL particles, and it's putting you at risk. When your HDL cholesterol goes down, again, that's the one we usually think of as the good cholesterol, what you can see is happening on these graphs is that your LDL particles are going up. And the LDL cholesterol doesn't reflect that, so you might misclassify somebody as not being at risk if you don't pay attention to the triglycerides and the HDL. So I want all of you, whatever lipid panels you've ever had done, be looking at that. And if your triglycerides are over 150 or even over 100, that's abnormal. If your HDL is under 50, that's abnormal as well, and that's your window. And that's really, really important to understand. I had skipped over a slide that I'd like to go back to talk about a concept called non-HDL, which I'd like you to at least be exposed to here. Have you ever heard of non-HDL? No? Okay. Probably the reason you haven't heard about it is that it doesn't come up on your profile. When you get your profile back, you get the triglycerides, the total cholesterol, the LDL, and the HDL. But you don't get the non-HDL. But you know what? You have it. You just have to calculate it yourself. Non-HDL is exactly what it says. It's everything but HDL. So you take your total cholesterol, you subtract HDL, and that's your non-HDL value. And non-HDL is basically a poor man's particle concentration. Poor man's LDL particle number. If your non-HDL is above 100, if you're a high-risk person, or above 130 and somebody who's lower risk, you have too many particles. And you can just assume that. So you should go home and look at your numbers and calculate your non-HDL. The way you calculate it is you basically just add 30 points to your LDL goal. So if your goal is 100, your doctor told you your LDL cholesterol should be 100, your non-HDL should be 130. If you're somebody who has had a heart attack or a stroke, or who smokes, or who has diabetes, your non-HDL should be less than 100. And if it's not, you have high particles, okay? You need to know this. And you should ask your doctor. Your doctor's going to be very impressed with you when the next time you get your lipid call, they call you back and say your numbers were fine. Ask them for the numbers, and then say, what's my non-HDL cholesterol? Got to get them thinking about that. And they should be calculating it for you, but you need to be asking that question. So we've talked about what the numbers should be. Total cholesterol less than 200. The HDL we've talked about a lot. Over 50 or over 40 for a man. Triglycerides under 150 is what is according to the National Cholesterol Guidelines. Most lipidologists would say closer to 100 is more optimal. That's because of the particles going up really over 100. And then the non-HDL between 100 and 130, depending on how high risk you are. So this slide, what causes high cholesterol, speaks to your question about what do I do? My number comes back abnormal. Does my doctor just put me on a drug? No. We need to figure out why. And if you have one of these things going on, if you smoke and your HDL is low, guess what? If you quit smoking, your HDL is going to come back up and you don't need a drug. You just need to quit smoking. It's the most common cause of a low HDL. If you have a high triglyceride and you are undiagnosed diabetes or prediabetes, guess what? If we fix that, your triglycerides are going to normalize, and you don't necessarily need a drug to lower triglycerides. We need to treat the root cause. And again, that's what we try to identify after we've identified people's risk, is why.